Good morning, good afternoon, good evening, everyone, and thank you so much for joining our ACNS YNS webinar series. Today is our special ACNS YNS webinar. It's a month of April special ACNS YNS webinar with the topic of research and publications. Today, our chair will be Professor Roger, who is a chairman of ACNS Educational Committee and also the professor at the Government Medical College and Hospital in Trivandrum, in India. Our expert speaker today, we have Professor Kostelin, who will talking about the topic of from the idea to the research to done. And we have Professor Ariel, who will be talking about the topic of the laboratory to bedside path. And also our YNS speakers, Dr. Alessandro Bravo, will be talking about my experiences in conducting a clinical research. And these three series of lectures are linked so that we hope to provide, educate a young neurosurgeon how to conduct a research. And also our special lecture today is by Professor Saito, who will be talking about the flow reversal with bypass for unkeepable aneurysms. Our discussion today is Professor Juji Inamasu and also Professor Olisen and also Professor Prison. Shall I invite our chair, Professor Roger, to introduce our speakers and also discussions today? Thank you, Professor Roger.
Thank you very much, Ben Sensei, for this wonderful opportunity, and I'm extremely honored. So, welcome to all the senior members of the profession, our very honorable President, Prof. 𝒂𝒃𝒊𝒂𝒍, and Prof. Alexander Wozniak, Prof. Inamas, Prof. Kostadin, Prof. Arion, and all my dear friends, my dear friend Liu Gun Singh, Prof. Inamas, Prof. Anyaku, and everybody. So we'll start today's webinar without much ado. And before we start, we will like to have our inaugural comments from very honorable President, Professor 𝒂𝒃𝒊𝒂𝒍. Sensei.
So, konbanwa minasan. Good evening, good morning, good afternoon, everyone. Thank you very much for joining today's very first initiative, the research conference of ACNS. I think we have a great speakers and also the commentator, so on. So very much looking forward to listening to lectures. Before that, I think Saito Sensei, again, thank you very much for your join.
Thank you
very much looking for your lecture. Thank you very much. Roger Sensei.
Professor Saito, we'll move on to listen very novel and wonderful lecture from Prof. Saito about flow reversal and bypass for unclippable aneurysms. So over to you, Prof. Saito.
I'm not sending my slide. Can you see? No?
Yes, we can see your slides.
Not yet?
Yes, we can see, Prof.
You can see?
はい、大丈夫です。
Yes.
はい、はい。わかりました。Can I start my presentation?
Please.
Yes, sir.
Okay, so I appreciate the Professor Hyoko Kato, the president of the ACNS Young Neurosurgeon Webinar, for giving me a chance of the lecture. So I present a flow reversal with bypass for unclippable aneurysms with 2 cases and literature reviews. So the surgical and endovascular treatment for giant or complex aneurysms is challenging. The aims of this presentation were to feature clinical characteristics of unclippable aneurysms and to discuss a better surgical strategy. The contents are as follows. A presentation of surgical cases of giant thrombosed aneurysms of ICA and MCA and literature reviews. This is the first case, is impending rupture of the left ICA giant thrombosed aneurysm. The patient was a 66-year-old woman, and she had a past medical history of hypertension. She presented with sudden onset of severe headache and observed the symptom at home. So she visited the neighbor clinic 3 days after onset. So MRI images at the clinic showed no subarachnoid hemorrhage and left giant thrombosed aneurysm. Neurological findings were allowed and no neurological deficit. Sorry. Yes. This is a MR SPGR actual coronary image. Sorry. Yes, sorry. This is the axial image. The image shows a partially thrombosed mass lesion adjacent to the posterior side of the left ICA, like this. Next is the coronary images, shows the thrombosed mass lesion was buried in the left basal ganglia. This is the left ICA angiography. It showed a partial intra-aneurysmal flow, like this. At the terminal portion of the left ICA. The right ICA angiography with MARAS test showed a good collateral flow via 𝒂𝒃𝒂𝒂. The 𝒃𝒂𝒂 was hypoplastic. This image is a three-dimensional ICA angiography. It showed perforators from A1 and M1 attached to the posterior wall of the aneurysm. So that shows a therapeutic strategy as follows. We harvest SDA for low flow bypass, and the left front temporal craniotomy was undergone. I checked the aneurysmal neck for clipping. But neck obliteration should be impossible, I think. So SDA MC bypass was planned when neck clipping was not done. So I planned for a flow reversal from end wall type to side wall type to promote intra-aneurysmal thrombosis following intra-aneurysmal flow reduction. For flow reversal, ICA is occluded at the distal side of anterior choroidal artery. If not, ICA is occluded at the proximal side of anterior choroidal artery and 𝒃𝒂𝒂. The bypass flow and 𝒂𝒂𝒂 cross flow to MCA and ICA perforators are checked with ICG fluorescent angiography. So next, the M1 is occluded for more cosmetic flow reversal. And so I check the flow, dynamic flow change with ICG fluorescent angiography under monitoring a motor evoked potential. This is the strategy. I'll show the video, surgical video. This is after the left side front temporal craniotomy. First, I open the cerebellum fissure, so we can see the M1. This is the ICA and optic nerve. So first, I secure the proximal portion of the ICA. This is the aneurysm, thrombosed aneurysm. The neck is very broad. So this artery is a small anterior choroidal artery. This is the terminal portion of the ICA. So we can see the A1 portion like this. This red wall shows up a partial intra-aneurysmal flow, I think. This is the just origin the perforator from A1. You can see. This is the M1. Okay, M1 is no adhesion to the aneurysmal wall. So we prepare the SDA parietal branch, and I check the bypass portion like this with Doppler. So first, I said I perform the SDMC bypass like this, using the 10-0 nylon suture. is intermittent suture is the 5 sutures after state suture. I think this is a standard technique. And after the bypass, so I check the bypass flow with Doppler. And the ICA wall strongly adheres to the aneurysmal wall. So this is the colloidal anterior colloidal artery. So the 𝒃𝒂𝒂𝒄𝒉 was hypoplastic. So first, so I occluded the proximal portion of the ICA like this and check the blood flow using ICG angiography. So we can see the blood flow to the IC perforators like this. This blood flow from low flow bypass or 𝒂𝒂𝒂𝒂𝒂 blood flow via 𝒂𝒂𝒂𝒂. And next is I tried the M1 occlusion like this. And I checked the IC angiography again. So it's a good blood flow outflow to the MCA territory. So no delay. It's I found, and the IC perforators. So we can see it from the blood flow from the 𝒂𝒂𝒂𝒂. This is the patient has no neurological deficit. The postoperative CT showed the progress of intra-aneurysmal thrombosis. This is postoperative FLAIR images also show the progress of intra-aneurysmal thrombosis without perianeurysmal edema. This is a left IC angiography. It showed no aneurysmal flow. And the SDMC bypass supplied MC territory like this. And postoperative diffusion weighted images showed a small infarction, but without new neurological deficit. This is a cerebral blood flow IMP SPECT showed no marked flow reduction in the left hemisphere. So this is a review. This case was an impending rupture of ICA giant pulsary thrombus aneurysm. Aneurysmal origin was broad from 𝒃𝒂𝒂𝒂 origin to A1 origin. The patency of 𝒂𝒂𝒂 cross flow was good, and 𝒃𝒂𝒂𝒂 was hypoplastic. A flow reversal of interaneurysmal blood flow was planned to change the hemodynamic state from end wall type aneurysm to side wall type aneurysm. Intraoperative evaluations were a direct observation of aneurysmal origin and monitoring of ICG fluorescent angiography and motor evoked potential. Next is case 2. That's left pulsary thrombus giant M1 aneurysm. The patient was a 55-year-old man. He had a hypertension of past medical history. He presented with transient right side hemiparesis. MRI images at neighbor clinic showed giant thrombus aneurysm at left M1 portion. He had no neurological deficit. This is CT. Showed a thrombus mass lesion adjacent to posterior M1 portion with perianeurysmal edema and all the infarctions in the left coronary theater. MRT2 star and FLAIR images showed partially thrombosed mass lesion adjacent to posterior M1 portion with perianeurysmal edema. This is a left ICA angiography. It shows a partially thrombosed giant aneurysm as a left M1 portion. This image is a three-dimensional left IC angiography. It showed a giant aneurysm originated from the left M1 portion, and two temporal branches like this originated from M1 portion. This is a key point. Other angiographies showed two branches of superficial temporal artery and good ACOM cross flow and patency of 𝒃𝒂𝒂𝒂𝒂𝒂𝒂. This is the therapeutic strategy. the important goal is flow reversal and flow reduction of intra-aneurysmal flow to promote intra-aneurysmal thrombosis. STA-MCA double bypass is set to M2 superior trunk and inferior trunk both. M1 portion is occluded as a distal to the origin of the first temporal, like this temporal branch. Undergrade blood flow from ICA flows out to the first temporal branch without blind alley of perforators. And bypass flow from STA-MCA bypass also flows out to the second temporal branch without blind array of perforators. This is the post-operative CT and showed progression of intra-aneurysmal thrombosis. So patient was no finding of no neurological deficit. And the post-operative MRT2 star and the FLAIR images also showed a progression of intra-aneurysmal thrombosis without new infarction. This is the post-operative left ICA angiography showed no flow in the aneurysm like this. The post-operative CCA angiography showed a good patency of a double bypass. And MR diffusion-weighted images showed no new ischemic lesions. The post-operative cerebral blood flow IMP SPECT showed no flow reduction in the left hemisphere. This is the review of case 2. This case was a giant partially thrombosed aneurysm as the left M1 portion involved with M1 perforators. The flow reversal and flow reduction of intra-aneurysmal blood flow were planned with STA-MCA double bypass. Sorry. The aneurysmal origin and perforators were directly observed. Intraoperative monitoring was ICG fluorescent angiography and multi-evoked potential. 2 temporal branches were used to flow out for ICA and bypass flow to avoid blind alley of M1 perforators. Next, literature reviews. Similar surgical cases of partially thrombosed giant ACA aneurysm was reported in neurosurgical review in 2016. The patient was an 80-year-old woman. Enlargement of aneurysm was found within 2 years. Sorry. The angiography showed a fetal type of 𝑃𝒂𝒂, and Alcock test showed involvement of the 𝑃𝒂𝒂 and anterior choroidal artery. Sorry. This is the Alcock test and the BAG Alcock test. This is the aneurysm, and we can see the 𝑃𝒂𝒂, and the involvement is like this. This is the also therapeutic strategy. This is very complicated schema that also performs 2 bypass, high flow bypass and low flow bypass of STA-MCA. The high flow bypass flows out to the distal portion of MCA, and low flow bypass, the blood flow from low flow bypass flows out to the aneurysm and the ICA perforators and the ophthalmic artery. This is the flow reversal like this. And this is the post-operative images. The STA-MCA bypass is the patency is good, and it's almost no blood flow of the aneurysm, only like this. So another literature review is another case report. This is the old one. It's reported in Surgical Neurology in 1994. This case was a 19-year-old man. The left side M1 giant partially thrombosed aneurysm. The size was 60 millimeters. The interesting point of this paper is authors selected the outflow occlusion with STA-MCA bypass. Sorry. This is the schema. This is the aneurysm, and also sets low flow bypass like this in the distal portion, and this is the outflow occlusion. And so the post-operative image is a very successful result. This is the authors discuss one strategy using the Bernoulli equation and simplifies according as the bypass situation. This is the difference of the blood pressure is the distal portion, it's pressure B, and the proximal portion is pressure A. This difference is dependent on the blood flow of the entry to the aneurysm. And the clot formation within the aneurysm is proceeded. This difference pressure is smaller, and if its entry velocity was 120, its the difference of the pressure is only 0.6 mHg. Next is a recent paper about the surgical distal outflow occlusion for the treatment of complex intracranial aneurysm. This was reported in 2015 from the National Brain Aneurysm Center at the John Nassif Neuroscience Institute. The objects were 18 complex aneurysms not amenable to standard microsurgical or endovascular therapy. The 18 complex aneurysms includes 9 cases of SH and 1 case of remote bleeding and 8 cases of unruptured aneurysm. So they choose the bypass and surgical distal outflow occlusion. So they discuss the result of the outflow occlusion for the intracranial complicated aneurysm. And this image shows a representative image is basilar trunk partially thrombosed giant aneurysm. So in this case, it's like this outflow occlusion induces a very good result. And the total result is like this. 16 cases in 18 cases, all cases was in 18 cases, in good outcome. And 1 case in MD, and 1 case in dead. I think it's outflow occlusion is the one therapeutic choice, but we have to check the appropriate indication. This is the last slide. Last 2 slides. The questions is like this: what is the good situation for intra-aneurysmal thrombosis? Bypass plus inflow clamp or outflow clamp? And what kind of bypass is suitable? And is flow out to adjacent branch necessary to avoid frinale or perforators? I think this is the questions. And so we have to challenge these unsolved questions. This is the last slide. So we introduced 2 surgical cases of giant thrombosed aneurysm treated by flow reversal using bypass and occlusion. Flow reversal is one of therapeutic choices of unclippable giant partially thrombosed aneurysms. Thank you.
Thank you very much, Saito Sensei. That was wonderful demonstration. I would like to invite comments from our very honorable discussant, Prof. Joji Namas.
Hi, Dr. Saito, how are you?
Yes, fine, thank you.
Yeah.
Is you okay?
Yeah, actually, I have known Dr. Saito for about 20 years, and he's a very good surgeon and both a good researcher. And I have little to say, but I need to ask some question about you. So,
okay. Thank you.
I have some question about the flow reversal technique.
Yes.
So when doing a flow reversal technique, the direction of flow is predictable or not after bypass by making a simulation with AI or something like that. So many.
Sorry, I cannot hear.
Cinema Sensei, your mic is muted. Can you please unmute?
I'm sorry. So
okay.
mic is on. So I have some comment, some question about the flow reversal technique.
Yes.
So when doing the flow reversal technique, direction of flow is predictable or not to bypass by making a simulation with the AI or something like that. So many years ago, Dr. Ausman tried to solve this question about the 1980s or 1990s. So many years ago, Dr. Ausman of Los Angeles tried to make a simulation after the bypass. So currently, the computer technique is very developed. So I'm wondering whether you can make prediction of flow after flow reversal technique by using a recent AI or something like that.
Thank you very much for your insightful comment. So I think it's a very important key point. So in my cases, so I could not predict the hemodynamic change, the post-operative hemodynamic change. So I used only the monitoring, ICG fluorescent angiography, and MEP and during surgery. So I could not pre-operatively, so I could not do the simulation of the change and the prediction. But and so I saw some literature, so you indicated, but no, I think it's no decisive method to predict the hemodynamic change after surgery, I think. I think important point is that we have to have some choices, and so during the surgery, so we have to check the all monitoring, so and we have to change the strategies from some choices. I think that's an important point.
Okay, thank you.
Okay, okay. Thank you.
Well, thank you very much. We have another giant with us today, Prof. Otani.
Yeah.
Otani, please.
Yeah, thank you. Thank you so much. Nice to see you, Professor Saito. Can you hear me?
Yes.
Yes, I'm Naoki Otani from Nihon University Hospital. So thank you so much for your great lecture showing your excellent technique for the bypass surgeries. And so I think so it's the most important thing is that how to preserve the perforators. How to preserve the perforators for in that case, in your these cases. So we have to avoid the directly flow out to the perforators as your presentation. So in that means your strategies is very suitable to preserve the perforators to flow out the main parent arteries. So and so my question is that so after the operation, did you perform the oral medication such as anticoagulant or antiplatelets, such as aspirin or Plavix or and so on? Did you so perform the oral medication after the operation in such case in these cases?
Okay, thank you for your comments. So I think so you indicated important point is how to preserve the perforators. I also agree that point. And so in these two cases, so I used single antiplatelet agent after surgery. Yes, and so we and I continue to the administration. Okay.
So and before operation, how do you think about the before operation?
Before operation, in these two cases, I did not use antiplatelet. Yeah. Yes.
Yeah.
Thank you very much.
Thank you so much.
Thank you.
Prof. Wozniak. Prof. Wozniak, are you here?
Yes, thank you. Yes, I'm here. Professor Saito, thank you very much for great presentation, for great excellent surgery and excellent cases. If to follow the idea of our today's meeting, I would to look at your presentation from another point of view. So you develop a new, very interesting idea of retrograde flow for providing of normal blood circulation at the distal region of the arteries. The cases you presented are very rare. They're almost possible to standardize, to randomize, and you develop this method from case to case based on your own experience and on the experience surgeon experts like you for many years, and so it's proven by the cases you showed made 30 years ago. It's interesting, but from my point of view, so at this point, I want to congratulate you that you are moving this idea and you try to develop it in neurosurgery. It's really impressive. My point that the weakest side of this method is that you cannot really cannot predict the flow volume from via the anastomosis to the anastom. And I think that small infarction in the first case maybe is the result of hemodynamic insufficiency of the anastomosis. So how how do you see the way to increase the blood flow via the anastomosis? Maybe there is a sense to do something like a hybrid high flow distal anastomosis to provide the retrograde blood flow. From the other case, the problem is that you cannot perform extra intracranial anastomosis before the surgery because you cannot provide the flow when you didn't block the artery, the antegrade flow. So from my point, the biggest problem is that not possibility to predict the flow wire. So how do you see the way to resolve this problem in the future?
Okay, thank you very much for your comment. So I agree with all your comments. So as your, I think it's your point. So it's very important, I think. And in my opinion, is the prediction of the blood flow after bypass preoperatively is very difficult. It's one important point, I think. And one strategy is from the previous literatures, the blood flow from high flow bypass, if flow in to the aneurysm, it's not good. So there are many reports. Okay, so I provide the when I select the high flow bypass, the blood flow flow out only to the distal portion of ACA or MCA. This is an important point of the flow reversal, I think. That's
yes.
And low flow bypass is safer. Low flow bypass blood flow to the aneurysm is more safer, I think. That's in first case. So I think it's a high flow bypass is better. And if I could do the M1 occlusion, I think it's an important point. Okay.
Actually, I thought about it when you presented. But anyway, it's in cases like this, only expert option, your option. There is no rules for surgery like this. So only you can decide the way to treat this patient. So and I congratulate you for the really great cases. Very difficult cases. Thank you.
Thank you. Thank you.
Thank you very much. We have a raised hand from Samsul. Yes, Samsul, you can ask a question.
Hello, good evening.
Hi.
Can you
Hi.
listen me?
Yes.
Yes, please ask your question.
Yes. Professor, thank you for nice presentation. I am Shamsul
Thank you.
Arifin from Bangladesh.
Mhm.
I would like to ask a questions in your MCA giant aneurysm.
Mhm.
For flow reversal, you did clipping, proximal clipping in the M1 segment after the perforators, right?
Sorry?
Proximal clipping of MCA, proximal to the aneurysm after perforators. So in the scenario where the
Yes.
yes,
So
in the scenario where the whole M1 segment is involved by the aneurysms, what will be your strategy for flow reversal?
So you mentioned the appropriate site of the M1 occlusion, right?
Yes, exactly.
Yeah.
Whether in that case, will you clip the ICA or you prefer the distal clipping?
Yes, I think there are many choices to treat that aneurysm, but for me, the important point was the flow out to the temporal branch. So to avoid making the blind alley, including perforators. Okay. I think that is an important point. So luckily, so that case has two temporal branches.
Yes, it's very unusual situation.
Yes, unusual. Yes, but it's very lucky. Yes.
So if it is not like that, that is whole M1 is involved. What will you do?
Yeah, that's very difficult, I think. So no flow out was, I think it's I occludes the ICA.
Yes.
And
I get it.
Yes, flow reversal from the low flow bypass all blood flow into the aneurysm, but the blood flow reduction, I think, promotes the interaneurysmal thrombosis. And
thank you, Professor.
Sorry, yeah, thank you.
Thank you, Shamsul. For your question, we have Dr. Jayanand Sudhir, who was our previous speaker as a bypass surgeon. Prof. Sudhir.
Thank you, Raja. And Professor Saitu, very nice presentation. I too have a small share of cases that I have tried flow reversal. And for one giant ICA bifurcation aneurysm, we did the internal maxillary radial artery graft MCA bypass. And we were able to successfully achieve flow reversal. And in that case, the outlet was just the ophthalmic artery because we ligated the ICA in the neck. And this patient did well. But recently I did one M1 segment giant aneurysm close to 5 centimeters. And I followed the same strategy as what you showed in the case today. Double barrel MCA bypass and proximal clipping of the M1 just proximal to the aneurysm. But unfortunately, I think there was a small perforator that was draping too close to the aneurysm. It was very difficult to dissect that perforator, and it was not coming into visualization despite me dissecting the M1 segment fully. So ultimately, the clip possibly caught that perforator, and the patient developed slight weakness. So the other strategies that we have adopted is just doing a bypass only for fusiform aneurysms in the perforator region of the M1. And this kind of cancels the flow from the ICA to a certain extent, reducing the hemodynamic stress on the M1. And we have at least 2 patients who are on follow-up without a proximal clip on the M1. These were 2 fusiform aneurysms of the MCA. So both the cases we have done bypass, and we are not clamped the M1 proximal to the aneurysmal segment, and both were fusiform aneurysms, and both are remaining stable, continuing on follow-up with us. Well, thanks. And also I need to add one more thing about the planning of such procedures preoperatively. The case that we did internal maxillary artery bypass to the MCA using radial artery graft, we have done a post hoc analysis using computational fluid dynamics. And I think the paper is under review in one of the journals and may come out soon as a publication. But in that case, we did not do a pre-op evaluation to see how we can strategize, but possibly that work will give some insights as to how to plan a bypass and whether a low flow bypass or a high flow bypass, and whether a low flow bypass actually will be sufficient to take care of the distal circulation before proximal ligation or proximal clipping. In a couple of cases, we found that the low flow ST-MCA bypass, despite doing a double barrel bypass, there were areas of low perfusion in the high parietal region. And we had one patient who developed multiple drop attacks after the bypass, and there was nothing more that we could offer. Over time, possibly it might resolve, but we did a MR perfusion and we found that there's a perfusion deficit in the high parietal region, possibly accounting for his drop attacks. Thank you very much, Professor Saito.
Oh, thank you for your comments. Thank you. Thank you very much.
Thank you, Jayanand. We can invite comments from Prof. Kato. Sensei. Please unmute your mic.
Okay, thank you very much, Saito Sensei. So estimation is very, very important, but still, so far we cannot. So, but ICG during the operation sometimes a bit late. In our sensei, he asked you. So maybe the most important thing is how to preserve the parameters. That is very, very crucial, I think. Thank you very much. Great your experience you can share. Thank you very much.
Thank you very much.
Thank you very much for your comments, Prof. Kato. If there are no further questions, I think we can move on to the research part of the webinar scheduled for today. So would like to invite our Honorable Prof. Kostadin Karagizio from the JK University, Japan, to present his lecture about from ideas to research questions, which is objective and aims how to write and how to come from ideas to a research question. So over to you, Prof. Kostadin.
Thank you very much. Thank you very much for your input, and thank you for your introduction. I would just like to
please share your screen.
Yeah, that's what I'm intending now to do. I hope you're seeing my screen already.
Yes, we are seeing.
All right. So let us go on the first of the two lectures that are scheduled for today, and they are related to the analysis and the practical research with junior neurosurgeons. We will be talking on 4 sections. So I have the first one, and that is related to the very early stage of the research in its inception. Definitely the idea, the research idea, the scientific idea has been very much in the focus of all the research that's been going on in humanity and so on. In all that process of generating an idea has been something very, very dark, something very, very unclear, something very difficult to explain. We have a lot of anecdotal talks about, let us say, Archimedes in Syracuse, who managed with an idea to understand if the crown of the king is made of gold or not, and Isaac Newton, who everybody supposes that while sitting and thinking under a tree, had an apple falling on his head. And by the way, the tree is still here in Cambridge, in front of the college. And finally, we have Albert Einstein, who was unsatisfied with the explanations by the classical mechanics created by Newton and the latest experiment that he was observing, he was intending to generate a new idea from the special relativity to the general and so on. So we don't have to really find immediate solution, just we didn't know and nobody knew, is this a serendipity in the background or was some kind of process which we can analyze. And in the last decades, the analysis has been progressing in a way that we can say to some extent about how from idea we evolved to the research product to at the end stage. We can roughly divide the whole process of idea development until the end in three major sections. And I will speak only on the first part, which is from the point of the inception of idea to the creation of a research design. This is actually at the time when the concept about the problem that exists has been created. The rest will be covered by my colleagues in the next lectures. How that thing actually starts. In this section that I'm going to talk today, we can clearly understand what are the steps that we have to follow and are somehow necessary for the development. First of all, every idea is related to a problem, and if this problem has no solution, the idea comes out because of the need of that. Further on, this idea will be developed as some kind of concept. That means the whole collection of knowledge around this idea and questions meaning and answers extracted, and that will generate hypotheses. And from those hypotheses, we are going to generate consequently the research design. So let us start with the problem issue. The problem is a very important starting point. We are facing them in our daily practice of different complexity, of different importance, and they are in all kinds of neuroscience activities that we perform in basic science, relation between phenomena and explainable causes. In translational science, we look usually for similarities between laboratory and clinical phenomena, how that can be implemented in practice. And finally, in clinical science, we have, as even today, plenty of diagnostic, therapeutic, and epidemiological evaluation. That is somehow part of our daily life. Now, the point is that we have to pick up a problem. We have to define it in the best way, as clearly as possible, and as narrow and focused on what it consists of as possible. Even at certain points, if we are able to define it as a logical Boolean relationship, that means that on the right is, let us say, a x together, y both, and so on. This kind of definition is very helpful after that to understand what kind of question we are going to ask. And usually this is a relationship between a problem and a solution. The problem and solution relationship definitely will be the subject of all this study, and started with the idea. What kind of connections and so on do exist? In science, particularly as a branch of psychology, exists a part of the so-called generation of ideas, which is called heuristics. And it is maybe more related to behavioral science, but that is exploring the general methods of idea generation and suggests divergent thinking, affective environment, reframing problems, and so on. And also is trying quantitatively to evaluate and trying to say which idea is more efficient. I don't think that is for our practical purposes of any use. So for our understanding as neurosurgeons, I would like to suggest several important points in the way we work on the generation of idea when we have a problem. The first thing is the brainstorming technique. I clearly like it. I definitely think it is useful, and this is usually a teamwork or a group work that is allowed to speak openly everything that comes to their mind. There should be no any kind of inhibition of the way the people think and express themselves, and there should be no criticism during the talk. It is very important, however, to make a very good record of what is generated from the ideas of the participants, and later on it should be analyzed. But definitely this should be before the systematic review, because the systematic review on the same topic will make probably a lot of influence on the way we speak during the brainstorming. In the next step, usually we have to review systematically. We have to approach all kinds of information that might be related to the solution of the problem. Starting from the top of the evidence pyramid, going down to the maybe even sometimes case reports, but in general, we have to extract as much as possible. What kind of similarities to our problem exist? Everything that can induce some kind of analysis and creativity should be encouraged. And definitely all the process of working on the problem to generate the proper idea is having to be documented and put down in written, because we easily forget that. Ideas easily fade. Even recently, with putting down all the notes related to some kind of subject or a problem as we are talking about, they can be put in a software that can be linking forward and backward and make a network like Obsidian or some kind of other. There are plenty of them now available. And we can easily detect the links between the different elements of knowledge that we have. But the easiest way, and also I'm advocating it, is the mind mapping technique. Mind mapping is something that connects different pieces, portions of knowledge or facts, and according to the relevance one to the other, they are organized in the form of a tree or a more complex figure. We can put quite in a mind mapping system everything. For that reason, which is something that might be more difficult, for instance, I have chosen two mind maps which are anatomical. Anatomy, even generated spontaneously by nature, can be mind mapped for the purposes of analysis. So mind mapping is essential, and particularly in the generation of the solution for any problem that can be crucial. We usually put the main idea in the center, and everything relevant to it is applied, organized, located, connected, and we will have some kind of a system of pieces of knowledge that can be usable after that for the organization of further analysis. So at this point, we can go to the second point of analysis, which is the so-called concept. From the idea, we have to make the concept. What is really the concept compared to the idea? The idea is the seed. It is the initial. Okay, maybe that can be a solution of that. However, that is not enough to be building some kind of sound, designable judgment or idea containing action from the very beginning. We need much more information that has to be around our idea to be able to put it in the proper way for further analysis. And the building of a concept is exactly that. The idea is inside the concept, and many other elements of information are around it, connected in a different way, and they are in between connected. So that kind of building of a concept is the basis of a real understanding what are we intending to solve. At this point, the concept has to be analyzed, and from this concept have to be defined several or at least one hypothesis to be able to solve our problem. How do we progress from concept to hypothesis? This is by analyzing what our concept contains. Our concept contains many links, but some of these links might be somehow beneficial to understand by further research what can be the solution. And now we have some kind of cause and effect, and there are several links, but these links existed before in the concept. So with the proper analysis, we should have been seeing them, and after that develop them in a certain kind of hypothesis, certain hypothesis with appropriate content for our research. This can be a relation between a method and diagnostic value, drug and therapeutic cure, and we can choose any pair of relationships that we are really intending to analyze. How we do formulate hypotheses. The research question that we have picked up from our concept, and with which in this concept it has been used for something as very practically applicable to the search of our solution, we can build the hypothesis. We usually define the hypothesis as null or null hypothesis as the opposite of what the expected relationship or effect is. And the H1, which is the main hypothesis, and that is the way of what really we do expect from from the investigation to be solved. And I'm making some very simple example here that an apple a day keeps the doctor away. There is a very funny English saying, but we know in the concept that there are a lot of nutritionally important substances that are important, that can have beneficial effect on the health. And the research question will be, if a person eats an apple a day, does that have any effect? So definitely the hypothesis will be evaluating some kind of category of the population. And we can do, let us say, over 60s, do they really go more frequently to the general practitioner? Or the null hypothesis will be just the opposite. Okay, but we don't work with apples, we work with the brain. So we can design the hypothesis in exactly the same way for any surgical methods and their outcome, complications, side effects, and so on, or symptoms and signs and diagnostic value, surgical findings and their relations to pathophysiology, pathomorphology. All these kind of pairs of investigations are very important examples that we can directly apply to our daily, let us say, thinking. Before we really approve our hypothesis, we have to see some other details about its feasibility. Is this this hypothesis really going to contribute significantly, or this will be just satisfaction of a minor problem that really will be not having any implementation or not any progressive understanding and so on? Is it possible to be researched in general, or it is dealing with the subject which is probably far away? And finally, do we have researchers and time and willing and resources in general to undertake the research? We still don't know how much will be that, but to undertake it. So we are reaching the final stage of our chain of evolution of the idea, with we have many parameters to define. The most simple thinking at the point we have a hypothesis and we evaluate the purpose, collection of data, how we are going to collect data to confirm or reject, or research methodologies that can be eventually used, methods of analysis, what challenges. However, that is not working, I will say, in the way we start unintentionally to build up some kind of plans. We need a completely well-organized systematic approach that will depend on the type of study. So we have to run immediately into the systems of classification of studies, of research studies that we have. In general, we can divide them in two, and qualitative are more descriptive, are not so much used in medicine, maybe for rare descriptions, single cases. Quantitative research is the real one, and that is the main approach in medical science. We have definitely numerical data, deductive conclusions, subjective and impartial observers. We need them, and so on. And definitely a clear hypothesis, which makes the relation with cause effect. Now, these are the characteristics of research, and they allow us to classify the cases, the types of research in according to the main characteristics they have. First of all, the data collection can be observational or experimental. So we can create exactly the data by our experiment that we have produced, or the causality relationships. The causality relationships are descriptive when they can be obtained just by observation, but otherwise they have to be obtained by analytical mechanisms, or in time, retrospective, prospective, single moment, a cross-sectional, clinical laboratory description according to the media discipline. Now, all this is the theory of how we have to see the different types of research. However, for the practical application of medical sciences, we have two major groups. These are the descriptive studies, in which we are really presenting the information that we have obtained, and these are case reports, case series, surveillance studies, small groups, and so on. Now, the biggest and more important, and as you remember in the evidence pyramid, much higher located, are the analytical studies. These are observational or interventional studies. Observational studies, we are observing cohorts in different points of time, or we use case control, the same patient before, after, or cross-sectional, as I already mentioned. But the highest part is with intervention studies, and when we have an intervention and a control group. And in this intervention and control group, the clinical studies are the most important. So for an example of the basic design of a clinical study, I have used, I will say, not clearly defined, is this an observational or an interventional, but the way we deal with the samples and methods is the most important thing in our clinical research. Our starting point is the population that we want to explore. It can be a disease with certain number of cases that we have observed, but they are part of a whole pool of patients with the same disease. So probably we are working with a sample, or we have a big sample of patients, but we cannot investigate it all. So we have to define a sample. And this is one of the most important points, that we have a number of n, which is our sample, and that is the group that we are going to use for complete analysis in our studies. The relationship between the sample and the whole population is very important. If the sample is definitely bigger, the margins of error will be narrower, and the power of the study will be bigger. After we have the sample and we submit them to the proper collection of data, We have a list of data that we have to do, and that collection of data have different parameters or variables, independent, on the independent. And all these data, quantitative and qualitative, I will say quantitative, numeric versus non-numeric, are collected according to certain protocol. In fact, the protocol is the beginning to the end written guide how to conduct the study. Once we have all the data we can definitely perform statistical analysis that provides, that depends on the variables that we have investigated and the results. And in the methods, we have the full variety of some of them are definitely statistics, but they are just defined clinical methods of blinding, randomization, selection of intervention operation, use of placebo, and so on. So that is the design and research design, which is the end of the first section of our research. We should not forget, however, that all this design, particularly in the clinical studies, is related to some ethical considerations. And these ethical considerations should be always minded, particularly recently. They are very rigorously reviewed by institutional boards, and it is a must for the performance. I have just found some kind of comments by famous researchers. They give their own individual suggestions. Contradiction is healthy, spirited debate, maybe a bit of competition, ideas, free time for thinking for clinicians, that is very difficult, and so on. Clinical, how different groups work in your field, what the other researchers in the same field are doing. These kind of ideas are important. But let us not forget, we need a systematic approach when we are performing clinical research. Non-systematic approach can leave us really stumble with pitfalls, which can be very difficult to manage. So let us summarize what I tried to say today. This is, first of all, define the problem to be able to generate the idea. Build around the idea the concept, that kind of complex configuration of knowledge related to this idea. Extract from this configuration the hypothesis. They are some there. If we are really analyzing properly, we are going to extract them. And after reviewing the research design and protocol, we have to be ready to start our research in the proper way. This is the sequence of tasks in the way we reach the solution, the problem with the research design. And finally, let us not forget that all this is really a lot of time and effort consuming. Our technological advancement is providing us helpers of different kinds, but we have to be always the main. And the AI, which is ready to help us, should be serving us and should be helping us and should not try to replace us. We should not allow it to replace it. So we should not stay away of it. Otherwise, our robots will take over. So thank you very much for your attention, and I hope that you will have a little bit more idea what we have to do when we face a problem. We have to find a solution. Thank you very much.
Thank you very much, Prof. Kozhedin. That was indeed a brainstorming session for us and as well as for all other young neurosurgeons. I hope what you said is absolutely correct. The ideas come from the population. Only the local ideas that arise within the population only will have a successful completion to a research product, because the available resources are the most important things that culminate from your ideas to a research. So we'll open this topic for discussion, and I'd like to invite Prof. Inamas for his comments.
Hi, Dr. Professor. Thank you for our lecture.
Thank you.
So thank you for teaching us how to think logically. So in Japanese medical education, we put importance in knowledge too much, and we have little training to think logically, particularly in English. So your student will very fortunate enough to have you. And I have some question about the AI or machine learning. Okay, so recently papers using machine learning are quite increasing rapidly. So let me hear you about your view, your opinion about the machine learning and the future studies.
Thank you for the question. It is a very important point. That's why I left as a last slide the AI to be really not forgotten. Recently, really, AI is interfering a lot with paper publication and able to replace some of the essential basic techniques of paper production. That means editing text, suggesting text. However, we remain the main owners and the generators of original idea. AI is still not able to be original in what we are doing. And number two, I will say that the translation of the facts from medical practice into facts that are computer processed is our duty and our ability only. So that point will remain both in the collection of data and the interpretation until the moment that we start generating a paper. I still believe that papers will be always finally produced by the researcher and the research team, not by AI. AI will polish them, AI can be analyzing them, and AI can find you if somebody else wrote about this 17 years ago somewhere in the other end of the earth. But no absolute replace. We will be always on top.
Okay, thank you.
Thank you very much.
Thank you, Prof. Inamas, for your comments, and Prof. Studying to let us know that we will always be on top of AI. So we can invite comments from our other discussions. Prof. Wozniak.
Yes, Professor Kārgļa, thank you very much for a great talk. Even inspiring talk. It's really, really, really. I'd like to propose you to move on and to lend the information to the real field, to the neurosurgical department. So there are the people who have the different roles, and usually the first problem is that the top neurosurgeon, the pet neurosurgeon, is usually a quite conservative person, because he has like an internal conflict, because he wants to avoid complication, to do the good job, have no complication, and not to use something new, not proven, and so on. So he always hesitates. But and usually there is a big role of young neurosurgeons who are the main generators of ideas in department. They look at the job of the chief, analyze and produce ideas. And the problem is these ideas must be heard and must be reacted by the chief of department. So in this topic, I would like to ask you to give some recommendation, practical recommendation about the internal organization in the neurosurgical scientific team of some separate department.
Yeah, I certainly imagine how busy you will be in your situation now as it is. And I completely agree with all your comments until the what you just expressed. However, in my opinion, the production of a scientific research is a daily work, and there should be some kind and some form of interaction on scientific topics on a daily basis. Even 5 minutes, 10 minutes in the most busiest days, there should be some kind of interaction between the boss and the juniors. In fact, the juniors are generating, but if this department is creative, depends on the boss. So I think it is very important that he is moderating all this environment, which sometimes goes into extremes, I agree. But it should be moderated in the proper way so there is generated production. If there is no generated production for the sake, let us say, of not having complications or this and that, that will be really impeding the progress of the whole department. Compared to other departments, there will be a discrepancy quite soon. So I recommend it as a daily basis. And in the place I'm working currently now, it is like that. We have quite a daily interaction on the ongoing research. The ongoing research is very well defined and it is reviewed constantly. So that is my recommendation. Okay. Yeah, use the ideas. Use the ideas of the juniors and moderate them and support them, and they can work a lot. They can produce a lot. They can be really creative and productive because the seniors can help them how to be efficient.
Okay, thank you very much. Thank you.
Thank you very much. We have several such brainstorming sessions in the morning when we were fellows with Prof. Kato. So Prof. Kato would like to say something.
Thank you very much, Konstantin. Very informative, very encouraging the talk. Thank you very much for YNS. So I think for YNS, is very important things is to write the case report at the beginning. It's very, it has a lot of the important things. Then to learn how to check the papers, and maybe once they present their paper, then some have such kind of a habit to write the paper of the case report. That's very, very important for them, I think. Thank you very much. It's very, very wonderful talk.
Thank you very much. It's very
Thank you.
Prof. Ahmad Fawad Pirzad.
Hello. Assalamu alaikum. Konnichiwa. Thank you very much. Sorry, that's today we have a problem with internet in Afghanistan, and it was excellent webinar. Thank you very much, and it's very important, especially research for young neurosurgeon and also for senior as well. Thank you very much.
Thank you to you. Thank you to you.
Thank you very much, Prof. Pirzad, for joining us from Afghanistan. So I think if there are no further questions, we can conclude this first lecture from the part 1 of the series of research. So in conclusion, I would like to say ideas comes from what everybody sees from a point of view that nobody sees. So to conclude it all. So now we'll move on to the second session, and we have very honorable speaker, Prof. Arion Kemosabeلیu, who is currently a research fellow in Canada. So he will lead us from how to convert your research from bedside to original research. So Prof. Arion, all yours.
Raj, can you see it clearly?
Yes, we can.
That's wonderful. It makes it difficult to follow Dr. Karagezzov in his work. As I'll try to outline, he has been a very important mentor in my path to research, and makes it a little challenging to follow him because I've never been into the standard of his acumen, shrewdness, both in clinic and research, but I'll try to be the student again. So the topic that I'll try to lay down, it's the lab to the bedside path, and I'll step aside as a researcher in Toronto, and I'll go back and be that young student when I was back in Albania. And this is academic work. There are no disclosures for my talk. If we were to go back, and I want to thank Raja for initiating and brainstorming on the potentials for us to bring and put together some lectures on the research. And I remember back in January that we had this idea that I may be preparing a talk on the topic of how to conduct research, either being that a project or a clinical trial. And somehow in my head, that was the original idea until recently I find that I was being given the transfer of work from the lab to the bedside. And okay, I thought that's another interesting point. So let's move on and build some thoughts and present it to the colleagues. So back when I was a resident, and very often I would face myself next to a patient, either alone or standing next to a senior of mine that was trying to teach and help me move on with the ladder of residency. It was obvious that on a daily basis, I would face questions that would pertain to how to better treat the case at hand. Was there a way out of the challenges of facing this problem and figuring solutions in a country with limited resources? And I want to make a point in this presentation that what I will be talking is mainly focused for us or for those that are currently practicing in low and middle income countries. The ideal path from the lab, where you have now the results and you want to bring it back to the bedside, in general follows this paradigm. The algorithm seems simple, but it doesn't always work. It's a tremendous and extensive labor back in the lab, where you have to work on the idea. The path that Dr. 𝒂𝒂𝒍 explained to us is what you have, your ideas, and then you want to go to the lab and you want to work your idea to produce the results that are going to be effective to give what you expect out of your treatment plan for your patient. So in general, two outcomes would come out of it. Either you treat your patient, and then finally you have brought what is being conducted in a research laboratory to the bedside, or on the other hand, you are still facing the challenge and you have not answered that question. So what you have to do is you be the student, and you are the student throughout your life. Either you are a medical candidate, either you're a resident candidate, or you are a young or a senior fellow neurosurgeon, or you are the chair. If you are the chair, you're all the same. You're going to be facing the same question: how am I going to be able to treat this patient in a better way to reduce morbidity, to minimize mortality, and potentially improve the quality of life of my patient? And that's a symbiosis in between research work and then putting that research work into the results. Back home, during residency, at the only training center in the country, I was trying to learn as much as I could, but access to research and research opportunities were limited. So to imply what we could improve in the quality of life of our patients seemed to face barriers. However, I would more often than not cross these borders of limitations using papers and internet resources to provide me with some sort of information that I can offer as a solution to the patient. It wasn't easy, I must be honest, and I would speak as a resident in a low income country. The opportunities for research were almost inexistent, or moving back and having what was applied back in more advanced settings of clinic and research, it was still somehow very challenging. So I had this lucky opportunity sometime during my training to visit for a week and attend a seminar in Salzburg it was in a way a window of eye-opening, because there I met a community of young neurosurgeons, mainly from Eastern Europe, somehow low or middle-income countries. I would say more of them were to the range of middle-income countries, and international faculty of neurosurgeons that were introducing us with the ideas of research and how to conduct work. But what stood out from my point of view is how those young neurosurgeons were eager, if not more, equally eager to bring their work from their institution, present it, and show how they are facing challenges and how they could offer some sort of solution to finding ways into treating patients, common diseases that our patients face, no matter where we are. I guess that extended luck moved on when I moved to Fujita for a period of fellowship, and it was the summer of 2008. I remember that time. From that small institution of mine, I was moving to a larger institution that had extensive and vast resources to be used into the work of research, either that being a wet lab research or translational work. You had the immense opportunity to see what was going on in real life in advanced setting. So as a young fellow, I was curious, I remained curious, and I came across many important points. And I would start that my story was that of a guy that was following some steps that were already grounded. I have a picture of one of our other fellows attending the fellowship during at the time, and I remember us very often going to a different part in our building when the fellows would stay and meet this gentleman here in the picture. Unfortunately, he's no longer among us. It's Professor Tetsuo Kano. He was an emeritus professor, retired by then, but see, Rahul Mali, one of the fellows, had one of the research works, and we were going to discuss that with Professor Kano. It was a constant work in progress. He had already refined his draft, and at that moment he wanted to have a second opinion from a senior neurosurgeon. But another point that I remember was that the former chair of the department, a world-renowned neurosurgeon, the pioneer and the father of the Asian Congress of Neurosurgery, even following retirement, was constantly remaining on top of his game. You could see on the table he had a set of markers that he would use for his drawings. Usual work at that time was he was working on meningiomas. What I want to say, research never stops. At any age of your life, if you want to be competitive and if you want to study and if you want to work the best to your patients, it's upon you. It doesn't matter if you're coming from a low or middle income country or your setting is that of an advanced surgical setting. You still need to do your work. Now, for me, back then, it was important to find mentors, to find those that would guide me walk through the path so I could build on the knowledge initially and then put that knowledge into work. And I found some of those wonderful mentors. Two of them are here in this presentation. I could never find enough time and to express my gratitude to my mentor, Professor Kato, as well to Professor Sano. And so goes to Professor Karagiozov, because somehow they took me under their wings to explain what typical work of a day of a neurosurgeon is, how you can combine the clinic and the research, and then how you should remain curious with your research ideas. It doesn't matter what quality of your research ideas you have. You do not criticize yourself, but you work on those research ideas for you to move forward. So at the end of the day, the algorithm that I showed you comes to a conclusion where you can bring what has been brought in the world before you and then apply it to the good and to the better treatment of your patient. We did some work. We conducted some research. It was the initial part of my work back at the Fujita. I remained in contact, but I remember this detail where I wanted to present some part of that work. I wasn't a complete researcher then, and I'm not a complete researcher today, even though some time has gone by and I've been working on my research techniques and have been trying to be more profound. But throughout my career, either in clinical research, I've tried to remain humble and have some sort of humility because I do not have all the answers. I remember this young fellow, it's Dr. Michael Kaplan. He's the current director of the functional neurosurgery and as well the program director of neurosurgery at Weill Cornell Medicine in New York. And I was presenting a paper on malignant stroke and a case report, as Professor Kato mentioned. We were working on that and conducted some research later on. But his question was very simple on the work that I presented. When would you put back the bone when you conduct a decompression in malignant stroke? I had no answer, and that was good. Somehow I was in a way feeling anxious because I thought I should have an answer, or maybe I wanted to have an answer to this very, very shrewd gentleman, but I did not. And I thanked him tons after that, because with that question, I went back to the lab to conduct more work. So tried myself to do the work. Later on, we were lucky to publish it. So we can, in a way, answer that question, when to get that bone back. If you were to decide that the patient needs the bone back, it's not in a week or 2 or 4. It should be scientifically based. What does that mean is that you take your question, either that yours or someone else, go to the lab. If you don't have a lab, you communicate with colleagues across the globe and you ask them the same question. And then you ask them if they would be willing to cooperate. So you put down that idea into work. And we were able to figure out that it's a window of around 4 to 5 weeks when microglia has settled into the border of the stroke area to the normal functioning brain, where is a junction of anastomosis, where it's telling you either from clinical science or findings of imaging, where you truly can tell your patient that now it's the time for us to put your bone back. And that's a simple example of how you take the knowledge of the lab, if that your work or not, or work that your colleagues have conducted, for example, those in Japan, and now you are implying that in a low or middle income country, as it was the case in Albania. I was back home, and the comparison of and that lack of interest into conducting research back home did not stop me from remaining in contact and building those bridges of communication with Fujita. And I never stopped doing that, but Fujita was my home, as was my institution, and I remained there after in contact with them. Now, I still was that kind of student without answers for some of the questions, if not many of the questions. I did not have the opportunity to move on and conduct research. I was still back at the same institution where it all started. But luckily there was internet connection for some good part of the day. And I would go out there and search and research. I would see what others were doing, because I was in a way thinking that if I am not able to conduct that research somehow, somewhere, someone has already done the work and has been enough curious to publish it. Now, you don't have a lab. You are a young neurosurgeon. You are a junior staff or a senior staff of neurosurgery in lower and middle income country. Even in advanced setting, not everyone is conducting research. But that does not, in a way, get in your work, in your clinical work, to provide the best to your patient. You remain in contact and you are connected with the world around you because, as I said, someone has already done some work on the questions that you have, and you apply that knowledge. On the other hand, if you have questions that you don't find answers out there, then you reach out to someone that already has a research laboratory, and you will find that the communication is important. Today we are using means of internet, and that's fantastic. It shortens the distance, it reduces the amount of time. But back to the day, and I'm bringing something from from a world-renowned neurosurgeon that happened to be here in one of the institutions in Canada. He communicated his ideas, his outcomes. Either those ideas or communications were those of success or temporarily failures to the world around him, and he remained in contact with that world, because if he had discovered something, he found it of great interest to share it with the world around. But on the other end, if you are the guy that want to find something, you go on and reach out to those professors, and you have two outcomes in general. The person that you are reaching out is going to give you an answer because they already have one. Or even if they don't have the answer, they are going to tell you, I do not have the answer, but let us cooperate and figure out if we can have an answer to that extent. And the other outcome is one that is very common. You reach out and usually won't get a reply. It shouldn't discourage you or give you a bad idea. In general, the internet is confusing to some extent. You see those very beautiful web pages where you would see names of researchers that somehow you think they have been conducting the world of research. In reality, they're just big names. So you have to bear that in mind, that not necessarily the picture represents the reality. So to find those bridges that you want to build as a young neurosurgeon or as a staff in a lower middle income country, it is for you to try to build those ways of communication with the world outside you. You do not have the resources to invest in laboratory research work, that's fine, but try to communicate with the world. That should always be the way, where you find those bridges of communication. It's not a one-day work, it's not a month, it's usually years of work where you remain in contact with, you reach out to a different researcher in Japan and then another one in Canada or in US where they are trying to do some groundbreaking work. In general, as I mentioned, most of the time those doors of communication are going to be closed because researchers are busy in their own world. Clinicians are busy both in the clinic or doing some research, and if you are not convincing enough with your research idea or what you want to study or how you bring something new in the field of research, that door is going to be closed and you're not going to have the reply that you want. But that's okay, because almost always at least one of those doors is open, and that is enough. That's what you need to give you a sight into what's on the other side, and that's where it's going to get you to the future. Now, you have to remain curious, because in your institution, you have limited. Okay, that we know. We are from low or middle income countries. We know that's not going to change in a day or in a year. You have to have more questions, and you have to work so hard that you can find those traveling resources, either being a mean of scholarship or fellowships, because you have to travel the world. You really have to see it with your own eyes, what is happening, and these are just a couple of my experiences. So then what can you copy from those experiences and bring it back home, that you can practice that better quality of treatment for your patients? At the end of the day, my philosophy that I try to share is your success depends on the quality of treatment of your patient. And if you want to be on that game, you have to have that clinician-researcher combination, at least in neurosurgery. I was lucky enough to travel. I was lucky enough to find those connections. I was lucky enough to build some work within the field of research, in addition to that in the clinic. And it happened to be at the University of Toronto, and currently in combination with the Cranwell Research Institute, which is a world-renowned institute in the field of neurosciences. Here we can do both research in the lab and then practice in the clinic. But because that's not enough, and it's always work in progress, you have what you find in the lab to learn. It's one thing, but to teach it back and to publish that, because you should never forget. I tell to myself, I cannot encourage everyone on that path, but I tell myself every day, you never forget where you're coming. You're coming from a low or limited resources clinic, now you have the opportunity to work in a country where resources somehow are way better. Then you teach and you publish that work, because the path from the laboratory research work and to bringing that down to the clinic is a journey. And you are just one simple piece, that's how I tell myself, of that journey, and you have to give back what you have learned. Now, publication success, in my experience, is inverse to procrastination. The more you procrastinate, the less you publish, the less work you put. But procrastination, still my experience, is somehow inverse to the skills that I had to build on being more organized and to schedule. I can explain and I can share tons of experiences going back to my work in Japan. I started building a schedule from early morning senior instructor to the fellow communications that we had with Professor Kado, to after work communications we had with Professor Kano, and at the end of the week communications that I had with Professor Karaguzov, which was helping me during my research work. Now I started learning. I was not good at those, and still to the day I'm practicing. So your organization skills are part of your persuasion. I think steps to the success combine this frame, this picture, for that success in general, to bring what you have learned to the laboratory, and then that knowledge of laboratory to bring it to the clinic. When it comes to the lab, and then you want to bring that knowledge to the bedside path. I am that young neurosurgeon that I was to the day, and still, I want to bring that knowledge back to my home country, which is a low or limited resource country, where I want to imply some better quality of care for my patients. And it's not only me. I see that in with admiration among other specialties and colleagues in preventive diseases, where they extrapolate knowledge from research work conducted in anywhere in the world where the opportunity succeeds, and put it down into the clinical practice in infectious diseases, internal medicine, hematology, and so on. In almost every kind of specialty, you can do that. Even if you have low investment in your work, you can still practice what you have seen, what you are learning. I learned something new today from earlier presentations in flow diversion in bypass surgery. Now tomorrow or the day after, I'm going to go in the lab, because I have a setting where I can practice some sort of bypass and see the idea coming out of the questions that you all had, and I can go back and bring that knowledge to my low limited resources country in Albania. When it comes for you to do the work, that's great, but you have to remember, or at least I tell myself, I did not come in this world as a product of only myself. If there was in any way some productivity in my research work, and that applying that to clinic, is because I had mentors. I was lucky. I was looking for them. I could find some, and then I remained in contact. But now you are not here at that stage where you are a young neurosurgeon. You have to give back to that community, and the community that I give back is connected to my past, to the current, and to the future. You remain part of that, because the engagement is what gives you the shaking of the brain, the storming, and then you produce new ideas. You may not be to the level of a mentor, but you have to honor your mentor. What that means, you do not forget the hand of help. How can you do that? My experiences have been very simple. Give back to the broader community of younger neurosurgeons or colleagues, because that's how you respect your mentor. Here I'm just showing a case of the respect that the world of neurosurgery gave to my mentor because of her commitment into spreading the knowledge, especially in low and middle income countries. She never stopped doing that, and she is still going on as she is strong. And for that, I'm very grateful, because I was part of that community and I want to give back to my community. Now, when it comes to the path, even though I am, in a way, a researcher, I must say, still in progress and doing some work. there are many questions that I don't have an answer. I work in a laboratory research in one of the most advanced. We have the opportunity to conduct research work to the extent of studying things that have never been studied, but I cannot do that by myself alone. So I go back and reach out. I'm just putting some of the faces of this international cooperation that has been helping me to work in the lab, but then bring those knowledges and put it in the clinic so I can help. And it's not only seniors. There are some seniors neurosurgeons in the finger, but I give back because I always remain in contact with medical students or with fellows. The current fellow here of Dr. Lawden is Reddy Rahmani, a brilliant young neurosurgeon that is going to be one of the, I hope so, one of the best cerebrovascular surgeons in North America. He studied with Dr. Lawden. We are currently conducting several projects together, but that's not all. You're part of the team, and that's how you bring your knowledge. You cannot do much by yourself, but if you work as a team, then success most likely is achievable, and cooperation is international. My current PI is a wonderful individual. I guess this is another lucky thing that has happened in my life. Dr. Ivan Radovanovic, another young neurosurgeon that has been practicing his work both in the lab and the clinic, and we brainstorm ideas very often, because that's how I see the progress in the field of research. Even if you are in a remote area where neurosurgery is applied only in the clinic and you don't have the opportunity to do your research work in the lab, you should reach out to your colleagues. In a way, I was looking for those colleagues and I could find some for bright minds, but at the same time, I still remain in contact with other bright minds because I want to learn more so I can bring what they have been doing into the field that I'm currently working. That was it for my presentation, and I thank you so very much for giving me the opportunity to come together in this community of friends and colleagues where I can share some of the thoughts in that very modest journey that I had. So I'm open for any questions you might have.
Well, thank you very much, Prof. Arian. That was very wonderful presentation, and we learned a lot, especially about the idea and how fruitful or difficult it is to find a mentor, and how you use your connections to build a larger projects from lab to a bedside research. So we can open this for discussion, and I would like to invite Prof. Inamas for his comments.
Hi, thank you for your nice lecture, Dr. Arian. So let me talk about the little bit about the Japan. So the problem Japan had right now is the decreasing the number of population, and the decreasing the number of the neurosurgeons, then also decreasing the number of the neurosurgeons studying abroad. So your lecture is very encouraging. And I encourage all young neurosurgeons listening to your lecture to go to other country, go abroad, and include Japan, and make and find many friends and many mentors. Actually, I and Dr. Saito, who gave a nice lecture today, spent several years together at Stanford about 20 years ago, and we have been friends since then. So I congratulate your postdoc fellowship and your future success as a neurosurgeon. Thank you.
Dr. Inamoto, thank you so very much for your comments. It's similar. That situation is occurring all around the world. Neurosurgeons somehow face long hours of work, not necessarily find that very interesting to stay in the business, and some of them are retiring early. There are other countries where neurosurgeons are no longer being interested to conduct research, and there are other countries where young students during medical school find it no longer interesting to apply into the specialty of neurosurgery. these are challenging problems we all face. It doesn't matter if you are from a low or middle income country or advanced country. And as the population is aging, I think we should brainstorm ideas how to help the younger generations of current medical candidates or graduates to attract them into the field of neurosurgery. I remember we met. I'm not sure you would remember me, but I've seen you in person presenting one of your talks from the work you have done at Stanford. I admire you for taking to the travel, because if you do not connect with the world around you, at least I tell it to myself, the world that you are, the world that I was very small and was becoming smaller. I could not see progress in the field. I could not see myself being challenged. I could not see myself remaining knowledgeable or facing the questions that my patients had. We have currently a postdoc research fellow from Japan in our lab, is Shunsuke Nimura. He's a very talented young neurosurgeon that I'm very lucky to work with. We work on different projects. He's currently conducting research on the genetic composition of the aneurysms and moyamoya disease. Even though we are in Canada and we have an extensive research laboratory work that we can do in the lab and then take that knowledge into the clinic, he is still remaining cooperative with his colleagues in Japan, because quite a lot of the work has been conducted in Tokyo, where he studied and he had his residency, and then we combine those findings. So success is not individual, it's a teamwork. And that's a lot of travel and communication with the world. Once again, thank you for your comments.
Yeah, thank you.
Thank you, Prof. Namas. Prof. Wozniak?
Professor Masabelio, thank you very much. A great presentation. It's based on your own experience. It's very emotional. So really, thank you. I also passed it through Salzburg. I suppose maybe we even met there, but I do not remember there. I've been there. So it was also like a good reminiscence for me. Really, you proved that the role of personality and personal intention is crucial for any scientific progress. And when it's supported by cooperation by the individuals who are united same idea, so it's a main base for the scientific progress in general. As some compliment, and what I want to tell some parable about Professor Rutherford physics. Once he visited at the weekend, he visited his laboratory and found his younger colleagues who was doing some. He asked, "Oh, my colleague, what are you doing?" He said, "I'm working." Okay. The next weekend, he also came to the laboratory, and again, they found the same guy. At the third time, at this situation, he thought, "My colleague, you always work, but when do you think?" So it's my comment to your lecture that the third path in the scientific process is to have a privilege to think and critically think and analyze the information. So thank you very much. Thank you.
Thank you very much. We can invite comments from your mentor himself, Prof. Kostadin.
Well, it was really very nice to hear the presentation of Dr. Arion, and I have excellent memories from the times when he was working in Fujita, and further on we have been constantly in contact and discussing many subjects. So I do expect that from his presentation we understand his approach to science and neurosurgery, and I expect a lot of success. I'm wishing him a lot of good success in his there. Thank you very much.
Thank you very much. Prof. Kato.
Thank you.
Sensei.
So thank you very much, Dr. Aaron, because still I remember, because still I have a very nice pictures, because you were sitting in the middle center among all the fellows, all the staffs of Professor Sano's department. And since that time, more than 10 years back, but still since that time, you were, maybe I think you could not understand the Japanese well, but I think you were always sitting beside me and also always a research mind. You ask me so many questions. I think it's very, very important as fellow. I really appreciate you choose Fujita since that time. All the best wishes. Thank you very much.
Thank you. Thank you, Professor Kato. Thank you, Professor Ķeqeř. And thank you, Professor Wozniak. Yes, I'm sorry we maybe did not run into each other in Salzburg, but you see, the world of internet makes the world smaller. We still remain in contact, we connect, and then I go back to connect with Dr. Ķeqeř very often. And I'm constantly in contact with Professor Kato. It's a way for you to grow. When I say you, I don't mean the audience. I tell that to myself. Have you achieved something, it's because you had the luck to study and work with some mentors that have helped you, have guided you. And the world that you are, it's not small. You see, I admire Dr. Wozniak that under the current pressure and the situation that goes on in Ukraine, he's here with us. I'm in the luxury of the quality of life that many people in the world would desire to have. It's safe. I'm not saying it's the safest country in the world, but it's safe in Canada. I wake up in the morning and I go to work at a safe place. But then when I see Dr. Wozniak conducting his clinical duties in a country under war, or the same is for Dr. Ahmad Pirzad. They don't have internet most of the time, but he always is present. I think that's the way how research is conducted. That's a way of research, and that's a way of thinking. That's a way of taking what others are doing and then taking it back to your clinic. So to all of you, I thank you very much.
Thank you very much. We have one raised hand from Irfan.
Thank you.
Irfan, can you please ask your question?
Okay, thank you, Raja. Thank you, Dr. Arion, for your nice presentations. It's very good opportunity for me to hear your journey. So maybe here, I think that I'm young neurosurgeon from Indonesia and currently study in Tottori University, Japan. And for me here, I think that the future to be neurosurgeon is, as you mentioned before, it's very long journey and very training. My question is that maybe could you give me any tips or trick how to keep your mental, how to keep to be happy during your journey to be neurosurgeon? Thank you.
Dr. Irfan, I thank you for asking me that question, but you see, do you really think I'm that smart that I can answer that?
Well, that is a question which researchers are conducting research on. How to be happy.
Exactly.
How to be happy?
Maybe just your personal opinion.
Yes. I'll try to share my personal opinion. You see, I'll go back for a second. When we all started the project of research, I wanted to be involved in it because it's a way to give back. And to giving back is you have to honor your mentors. As I said, I was lucky in my journey, but at the same time, you have to put your work. You have to come with your own self. And my own self back then was, and I must be honest, I was ignorant and I wanted to learn. I had no knowledge of general research, but I wanted to conduct that and I wanted to connect with the world. If I speak English today, somehow better than yesterday, I can tell you this other thing. Your English today, you at Fujita, was way better than mine back when I was at Fujita. And I started working on my English with all the colleagues there. And I'm going to bring back a conversation. This is a private conversation that I'm going to share with you. I had with Professor Kano. You are at Fujita. I will encourage you to read the history of Fujita. If you have done that, that's great. But there is so much of history of Fujita. And one of the important ingredients was that passion that Professor Kano had in himself. He saw his world being advanced. It was Japan. But then the world around him was not so advanced, so he wanted to extend that advancement to the world next to that. And he was telling me one day as I was out with Dr. Rahul Malian, and we had another fellow, Pratush Chowdhury from India, a brilliant young neurosurgeon. I remember Professor Kano telling us that he wanted to share his knowledge. And in his early days in a career of a neurosurgeon, his limitations was knowledge of English. So I had that with me, and I said, okay, if you want to communicate with your world, I am from Albania, the world is not speaking Albanian, I must learn my English. If I am doing some sort of research, back home we had archives of our work, but we were not publishing. Then you go back, you sit down for hours, just like Dr. Wozniak said, you need to work on your weekends and after hours to put those data. If you are a genius, you won't need too many weekends. You can do that in a week or two. Brilliant. That's you. Great. But I wasn't. So I had to work after hours. I would work on weekends. But life is not always work. So at Fujita, or at least I must share the experience of Fujita, the after-hours activities were so important for my brain to rewire, for us to take a break, and for the quality of life to go out of the work. We had pagers, and I don't know how Professor Kato could do it, but there were hours that I wanted to sleep. Dr. Irfan, I really didn't want to go to the OR. But then the pager would buzz, so I had to wake up and I would go and follow Professor Kato. Yes, I was tired, but I was learning. And then after the surgery, Professor Kato would take us for dinner or for lunch. So there is a balance. I'm not sure if you would be able on your own, but I was trying to find my balance. And my balance was remaining curious, asking the questions and trying to explore the answers in the lab and in the clinic. And if I did not have a lab, as if I have today here in Canada, I would read the books. And I wanted to be that humble and humiliated guy that if I was asked a question, I would say, okay, I have the answer. But if I didn't, I would say, okay, you know what? I don't have the answer, but I'll go and read. And the balance for me was a connection and communication with colleagues at work, the team that I was working, with the family after works, and an extensive group of friends that I connected with, and then I grew that friendship. And then activities that had nothing to do with neurosurgery and research, unwire, unconnect. Life is not only neurosurgery, it's not only research. So I can share with you a simple schedule that I have, which usually goes to the late hours of the day, but it's not only neurosurgery and research. There is a lot of other things. And I find that combination of these things make me somehow who I am today. So I thank you very much for asking me that question. I hope to have given you some sort of insight in my way of doing it. So thank you. And good luck at Fujita.
Thank you. Thank you very much. We have one last question we can take from Ikechukwu Aniyaku. Yes, Dr. Aniyaku. Please unmute your mic.
Yes. Okay, thank you. Thank you, Raja. My name is Ikechukwu Aniyaku, a young neurosurgeon from Nigeria. Yeah. Good evening, Professor Kato. Good evening, good morning, good afternoon, professors and colleagues. Thank you, Arion, for this presentation. I found this your presentation very inspirational. It's good to hear this kind of talk, because those of us who are still growing in the field, I found connect with the world, wherever you are coming from, connect with others outside your area so that you can grow. And then, importantly, whatever you learn, bring it back home and share it with your people. And that's the only way, when we talk about global neurosurgery or global surgery, this is the only way everyone can gain from the other. So it's just a comment of commendation. Thank you so much, sir. I so much appreciate.
Thank you.
Thank you so much, Ikechukwu Aniagwu. I'll try to pronounce your name. I hope I did it right. And putting to that to those comments, let me add something to what you just said. I'm coming from a history of a country that did not have research, did not have much to invest in research. But we know our home better than anyone. We have had visiting professors coming to be willing to share their knowledge. Usually our first contact was Italy, the country of Alexandro Boaro, because we are very close with Italy. But that was not enough. We had to do our work. The reason we had to do our work because we speak with our patients like no one. And I trust that in Nigeria, even if Professor Spetzler or Michael Loudon is going to come and practice, even if Professor Kato, which travels the world, is going to come and do some surgery, even if Professor Karagiozov is going to come and show you how the research is done in Japan and how he has done it himself. And then even if Professor Wozniak is going to come and tell you, hey, I've been working under very difficult circumstances and I'll show you my way, we still need to do our work because we are those who know the language, how to communicate with our patients. And that's the key to success. But if we have not matured our knowledge, our ways of research, our ways to bring what the world is doing to the field, then there is no success. I know that my country is going to fall behind. I know that I'm not sure about Nigeria. Maybe Nigeria has a large community of neurosurgeons that are advancing the field. But in my home country, if I don't do my work, my patient is going to suffer, and I don't want that to be part of my career. So thank you very much for getting with your comments. I appreciate that.
Thank you very much. So now we'll quickly move on to the last talk of today, which is from a young neurosurgeon, Dr. Alessandro Boaro from Italy. Will be sharing his experience about conducting a research. Alessandro, all yours.
Thank you. Good morning, good afternoon, and good evening to everybody. First of all, I want to thank Professor Kato for the invitation and Professor Cuti for the introduction. And also, I want to extend my thanks to all the previous lecturers for providing such beautiful presentations, as well as insight in both the professional and personal life, which are really priceless. I'm going to share my screen. Okay. Can you see my presentation?
Yes. Yes.
Okay. Perfect. So I'm going to share a little bit of my experience. So when we talk about research in general, we can think of a different way to characterize it. We can think about the type of clinical research we want to pursue, which can be either qualitative or quantitative. And in our field tends to be more frequently the quantitative ones, because we're trying to measure factors, to measure variables, to try to characterize elements that can help to arrive to results and improve patient care and patient outcomes. We can focus on different research categories, from the diagnostic to the intervention or the evaluation of prognostic factor that can help in foreseeing what is going to happen and to adapt our strategy. And obviously, as we saw in the first lecture today, the choice of the different designs, depending on the type of research questions or the results that we want to arrive to, are of paramount importance. And the choice between the non-experimental or the experimental design, as well as once we we get together all the data that we need, the correct way to analyze them, depending on the type of data that we acquired. And finally, when we put everything together, try to provide the results and provide the data and the information that we got in the most informative and in the best way. But in order to tackle all these different elements, we really should develop a whole series of webinars. So what I'm going to focus more about in regards with my little experience is to understand what is the best environment one should develop around himself in order to excel in doing research and how to start and how to proceed in a surgical career and in conducting a clinical research. So as you can see in this simple plot, the amount of research and time and effort that the person interested in doing so is put into place tend to increase over the course of a life, over the course of the career, with maybe the exception of the highest level of academic position, where the role tends to transition towards guiding the group, guiding others in doing the actual day-to-day on data research. But in general, as Professor Musabelli said before me, one of the first and foremost element to conduct a clinical research and to start a research career in medicine is to find a mentor, or even better, more than one. I was lucky enough during my residency program back at University of Padova in the Hospital of Treviso to have Professor Pierluigi Longatti to guide me towards this. And I used to work in a place where the clinical work, the day-to-day clinical work was really overwhelming, and there was the risk to not having enough time or to not be able to put enough effort into research. But Professor Longatti was really decisive and insistent in a good way to push me towards doing that, to develop my research skill and to study in order to be able to do research on my own. And after, at the end of residency, I moved towards the United States for a 3-year period, where I did both a research and a clinical fellowship at the Brigham and Women's Hospital at Harvard. And that was where really the environment that allowed me to develop, once I built my basics, to develop my more advanced surgical, research skill and factors that allow me to develop my ideas and my project. And I have to thank Professor Timothy Smith for this, because he was really the one welcoming there and start teaching me how to proceed and how to develop a more complex research pipeline, and also giving me the space to develop my ideas and providing me counsel and guidance during those days and those years. And really the first thing about doing research and conducting a clinical research is to study. As Professor Cato said some time ago during this webinar, one of the first thing that a young researcher or researcher-to-be can do is to write a case report. Why is that? Because during the clinical practice, we can find some peculiar case. And so this is a perfect way to start to learn how to write, as well as to search literature about that particular topic. And this is a good way to start getting into knowing this topic and become accustomed and proficient about it. And going forward, the ability to search the literature and also to develop research projects about what is in the literature in the form of reviews. And here we can see different ways of doing that, which are obviously some are simpler, some are more complex, some necessitate more study and more effort. But really this approach allows you to become competent in different areas and to start to publish and understand what are the factors, what are the elements that are important in doing your work as a researcher. So these are just a couple of examples of what I used to do. My actual one of the first work I did was this case report on an osteoblastoma on a young child, which we operated on back when I was in residency. And from there, I started to do in different review jobs, from a narrative one to systematic one, to even do a meta-analysis, which is the pinnacle of complexity, and try to make sense of what is in the literature about a specific topic. And as you can see, the topics of the study are quite different from one another, and I think this is okay, specifically in the first phase of learning how to conduct a clinical research, because it exposes a younger researcher to different topics. But on the other hand, once when we start to learn and to master our basics, I think it's also important to find your focus, to find some topics that are really of interest for you, that can produce important questions to be answered, and so you can pursue with your research effort. In my case, my high-end interest is towards spine and spinal cord surgery, as well as the application of new technology to neurosurgery. And so I started, when I was back in Boston, to develop an application for smartphone to follow patients before and after the surgery. So in order to have an objective measures on how the patients were recovering from surgery, along with other examples in different fields. And one thing that I found really important in how to conduct a clinical research is really to consider where you are. Because, as a previous lecturer said before me, now the globe is all connected. There are higher possibilities to work in different countries with different resources and different considerations and different characteristics. We have to consider this in conducting a clinical research. So I can provide this example in my experience when I used to work after residency at Harvard, and how I'm working now at the University of Verona. So to provide some examples. If we think about conducting a clinical research, first and foremost, we have to provide and write an IRB. We have to have in mind what is important for the study, how we're going to conduct it, and how are we going to treat the data that we're gonna use. And so this is already one important thing that can distinguish two different countries, because in the United States, these elements are regulated by a set of rules in the IPA, while in in Europe, in the European Union, the GDPR from a couple of years is now setting the rules for this. So we really have to be informed about these different rules on how to conduct clinical studies. Another element to consider is how we are going to have access with data that we're going to use for our research project. So, for example, when I was back in Boston, there was this very useful tool, the RPDR patient database, where inside the hospital and the clinics, we could search and filter different patients for different pathologies, different factors, and this was very useful in the first phase to understand how many patients we could have on a specific pathology, and so where to start. In the hospital where I work now, there is the hospital database, but we don't have a research-oriented tool that we can use to ease this part of work. And so there is a little more of effort in doing that. With regards to funding opportunities, that's another important thing. If you think about differences between the United States, where it's easier to apply to big national grants, when it comes to Italy, for example, or single states around the European Union, this can be more challenging. And so in our mind, we have to try to go beyond our national limits and try maybe to look into a European wide association or funding schemes that can help in developing our clinical research. And in my personal experience, because when I arrived in Boston, I was part of an ongoing project, so I was a little gear in the complex mechanism. Obviously, my role was simpler because I was working on a big team. I was doing my part while learning about the whole project, but still my part was small. When I came back to Italy, to the University of Verona, and I wanted to continue to provide to research in the same area, at that point, I was the one who had to start the project. And to start the project is really a different thing. You have to take into consideration additional elements that allows you to grow, but makes also the work more difficult. And I want to stress a lot this factor of the importance of collaboration. And the collaboration can go from just talking to a colleague of ours to how to download the articles and how to do the data extraction for a systematic review, up to talking to the Department of Statistics to help you in the analysis. And so it's important to develop to speak the same language and to be able to understand each other. We don't necessarily have to have all the expertise. Everybody have the expertise on everything, because this is impossible. But to develop the same language, that's really what can foster the opportunity of collaboration and make the work of conducting research easy. Again, it's important to have distinct roles on the other side, because the bigger the project, the more different roles there are, and so it's important that everybody do their work. And as we said previously, it's important to plan the flight and fly the plane. This is taken from what pilots do, what pilots do on a daily basis, in order to provide efficient and effective clinical research work. We have to have really in mind what to do from the start, and being able to, once we make a plan, to follow it. Because the last thing we want to do is to find ourselves in the middle of clinical research and understand and think about another variable we would have want to acquire to improve our results. But at that point in time, it's very difficult. We can't go back. We can't go back in time. Just a couple of words about artificial intelligence in clinical research. Obviously, AI is the topic of the moment, and there are really different ways in which this technology can help in different phases, from the preclinical part to identify higher risk compounds or predict toxicity, or again in the design, optimizing the protocols designs, or maybe to improve the matching of patient to potential trials, or again and obviously in the analysis phase to handling better missing data, or maybe allow a more complex understanding of the data themselves. And this is all good and well, because AI are a lot of techniques that can be very powerful. So it's good to be able to understand them and to use them. We also have to make sure that we are handling them in the right way. And when we talk about the application of AI in clinical research, data curation becomes an additional challenge, because as this algorithm tends to be trained on a lot of data, to be able to make sure that all of this data is data of high quality becomes an additional challenge. Also, the physical effort in trying to acquire enough data, specifically in the clinical environment, is not easy, because the amount of data that we have access to is not necessarily big enough. With regards to liability and generalizability, I think these are two more very important elements in consideration of this the application of AI techniques, because we always have to think, regardless of the implementation of AI, we always have to think of the repercussion that our results can have on patients' life, on patients' care. And obviously, when we start to include analytical techniques and tools of increasing complex, this can become a more slippery slope condition to understand. And I redirect you to this website, which is basically a web page from the European Union Commission, where it's talking about providing information about the AI Act, which provides a framework, not only regard to research, but in general, in all human activity, to try to characterize and understand understand which AI techniques should be more under control or better characterized in order to be beneficial to human and less harmful as possible. And finally, I want to stress also a lot about the importance of communication in this kind of project, because more and more now, along with clinicians and surgeons, data scientists are going to be part of this project, because it's impossible for us with our busy schedule to be able to develop these complex techniques, while the possibility to characterize from a traditional statistic point of view our data is something that we can still do. And so it's really important to be able to speak the same language with this additional counterpart. And this is really, I think, the key, the real key to be able to implement these techniques in an effective and efficient way. Finally, I'm going to leave you with the last slide, which I think really is what is most important about what we all talked here today, which is be passionate. Because regardless the amount of hours and the amount of clinical work that you want to do, that you have to do, if you want to pursue a clinical and a research career and to effectively conduct a clinical research project, you have to be passionate, because this is what will allow you to proceed in your career, and to, even if tired, as Professor Mus-Abilis told you, to be able to wake up at the sound of a pager and still be willing to keep learning and keep producing good work. Thank you very much.
Thank you very much, Alessandro, for providing the skeletal framework of how you go from ideas to project completion. So I'd like to invite our chair's discussions, Prof. Wozniak.
Dr. Baura, yes. Thank you for excellent presentation, and I congratulate you with the excellent result you showed to us. And my comment is that the scientific work is only part of neurosurgeon's work, and another part is the practical training, and they must go both aside and move together. And so I wish you to have the same progress in your professional neurosurgical skills in the future. So all the best. Thank you. Thank you very much.
Thank you very much, Professor. You're absolutely right.
Thank you very much. Yes, Ben, you have raised your hand, Ben.
Yes, and thank you so much, Dr. Bravo, for your sharing. And I like not a particular question, but some short comment. And I thank you so much for joining, first of all. And I like your final saying, be passionate. And you echo with Professor Arion that even though if you're tired, and you still need to learn and be passionate and improve yourself. And that's very important message to the young neurosurgeon, including me. And this is very inspirational. I would say in general, this series is a very inspirational series. And we have Professor Kozidin to start with, explaining the research, the idea, as a mentor, from a mentor's perspective. And then we have Professor Arion and Dr. Bravo sharing their experience, their journey to accomplish these results in terms of research, and making step-by-step improvement and step-by-step instruction how to do it. And this is very important to us. And again, I would like to echo with Professor Arion and Dr. Bravo that finding a mentor is very important in achieving this result. And it's the same over the world. And it does not limit by the border of countries. But is the same across the world that we learn from our mentor. And I would like to thank you to bring this, not a particular neurosurgical knowledge section, but a research, in this research session of this very important message. And I would like to also thank you, Professor Kato and Professor Kozadin, and also different professors of the ACNS, and to educate us, the young neurosurgeon of different neurosurgery and also research. And I wish you every success for the ACNS. Thank you so much.
Thank you, Ben. You can invite comments from Prof. Inamas.
Thank you so much for your lecture, Dr. Burrow. Sono appassionato, molto importante. As we mentioned, regarding writing a paper, I agree with you that the starting from case report is the best way to do that. And also finding a good mentor is also important. And in addition, I like to stress the importance of the statistics. So collaboration with the statistician is very important as well. And also you have to learn statistics yourself as well. And also so you have to be knowledgeable about the how machine learning works, because recently the papers using machine learning as a statistic tool is increasing very rapidly. Thank you for your lecture.
Thank you, Prof. You're absolutely right. I think that the difficult thing about AI in terms of being able to do themselves is the amount of work that goes behind, not only on the development of the algorithms themselves, but also on the data creation themselves. So that's why I wanted to stress how much important is collaboration in these regards.
Thank you, Alessandro. Prof. Kato?
Yeah, thanks so much for Borrow, that you are maybe the colleagues of the Dr. Albert, right?
Yeah,
okay.
Absolutely.
Thank you very much. Your talk, I think especially recently, the robotics or AI or minimally invasive is very getting popular. I think your generation maybe sometimes to change the whole concept of the treatment of the neurosurgery, I think. So maybe you can focus on that, writing some paper in that point, I think. Thank you very much. All the best wishes.
Thank you very much, Professor Kat.
Can take short comments from Prof. Arion.
Ben, thank you so very much for the great work that you do. You bring yourself, you lift up those young colleagues and neurosurgeons around the world with your outstanding work. You take hours out of your life to remain committed to a greater cause, which is that of young neurosurgeons of the community. So I thank you very much for the great work you do. It's outstanding. Masu Sensei, you surprised me with your Italian. It's great. You caught me off guard, but Guaro, è veramente un lavoro straordinario. I miei sinceri congratulazioni, perché non è facile lavorare e pure fare e condurre il lavoro scientifico. So with those in mind, I admire for what you're doing, because it's not easy. But Professor Wozniak is right. It's time when you need to do your research, and that's a time when you need to do your clinical work. I think you can combine both. There is no limit of age or time or place where you can do an outstanding clinical work and then do some good scientific research work. It's possible. At the University of Toronto, there is a practice of training and education where usually at the 4th year of residency, most of the residents' core will pursue a path in graduate studies, usually to the extent of doctoral studies, a PhD, not only master's. yes, of course, we have the support, we have the financial means, and a student can feel confident to pursue that path, but it's not easy. So for those in limited and low and middle income countries with limited resources that are conducting that work, it's outstanding, it's astonishing, and most of the good quality results come from those countries. I have experienced some wonderful publications coming from countries that don't have a laboratory. So I thank you very much for bringing here your combination of works from Italy all the way to US, and then going back to implement that knowledge. That is the most important step. You learn, you remain curious, but if you don't invest that back, if you don't plant that seed, then all those years of investment are wasted. So I wish you the very best. I miei sinceri congratulazioni nei prossimi, in your next steps. I think I'm forgetting my Italian, so I'm sorry about it.
Well, thank you very much, Professor Mus-Abellio, for your kind words, both in Italian and in English, as well as Professor Inamasu. You are completely right. The nicest thing that we can do is, once we learn something new, to come back to where we can improve the situation where we started from. And then, yes, I'm starting to do this, and hopefully we'll go doing that for a long time.
Well, thank you very much. So we can wind up this session. We have 2.5 hours of exciting and very knowledgeable brainstorming sessions about research in neurosurgery. So we can wind this up. We'll come back with the second part on the 28th of this month. And I would like to invite Prof. Kato for her concluding remarks.
Oh, thanks so much. So just I want to tell that Inamasu Sensei is a good, I think, researcher. So his brain is always thinking what's new in neurosurgery. I think it's very, very important to think what's new. That always Professor Kano talked to us. We listen to so many nice research work, and also I think interaction. Maybe the senior doctor who talked today, but maybe you can reflect from the good response from the young doctors, especially Dr. Ben. So we look forward to the next research webinar in 28th. Thank you very much. Saito Sensei, ありがとうございました。
Thank you.
Ben?
おやすみなさい。
Thank you. ありがとうございます。
Thank you, Ben.
大沢先生、ありがとうございました。大沢先生いたんですね。おやすみなさい。
Bye. See you all. Bye bye.